Hello and good evening, I'm Melisa Idris. Welcome to The Future is Female. This is the show where we find the extraordinary in every woman. Now, pain is one of the most universal human experiences, but it's often dismissed and undertreated, especially in women. So that's why I'm particularly excited about the topic tonight and delighted to introduce my guest today, Dr. Mary Suma Cardosa, who is a consultant pain management specialist who has spent decades changing how Malaysia understands, measures, and treats pain. She was the first female president of the Malaysian Medical Association and the past president of the Malaysian Association for the Study of Pain, to which she still serves as an advisor. And she's currently the president-elect of the International Association for the Study of Pain. And she is the first Asian person to hold that position. I'm so honored that you are here on the show today. Dr. Mary, welcome.
Thank you, Melissa.
Right, so I want to focus on pain because I think it's fascinating. Everyone experiences pain, but sometimes I think pain is misunderstood, it's minimized, dismissed. So let's talk about that. When you tell people that you are in the field of pain management, that you specialize in pain management, what is it that you think people usually don't understand or misunderstand about about pain in general?
Right, that's a very big question.
It's a big question, yes. But when you say I'm in pain management to somebody, what is it they assume you do, and what is it that you hope they understand you do?
So most people assume that pain management means taking away pain. You know, that relieving pain, which it is, but what a lot of people, including healthcare practitioners, don't understand is that we actually should separate pain into two big categories. One is acute pain, which is associated with injury.
Okay.
So if you have a fracture, if you fall down, you have a cut, or if you have surgery, that is what we call acute pain, which is related due to tissue damage. And that's protective, that is good, is what you could call good pain, if there's such a thing. And that pain goes away when the tissues heal.
Okay.
So if you've had a fracture, you immobilize the limb, you know, and then once the bone heals, there won't be any more pain, in theory, okay? That is acute pain, and that is treatable usually because it's short term, and we have enough medications and techniques available to us in the medical profession now to be able to treat acute pain, to be able to almost get rid of it completely. But you know, you don't need to have, so we measure pain on a scale of 0 to 10. The person in pain will tell, it's a self-report.
Right.
You know, the person in pain will tell you how much pain they have, and then you can treat it. We don't really need to go down to 0 because usually, you know,
there's a manageable
0 to
level
3
of pain. Okay.
so that's our goal, less than 4.
Okay.
So mild, no pain to mild pain, okay? Because people usually can function with that type of pain. So for acute pain, it's possible for us, we have the drugs and the techniques to reduce acute pain while the tissues heal. Once the tissues heal, you don't need the medication anymore, right? Because the tissues have healed. Of course, there are physical methods as well. You can use ice, you can use all those different things as well. So there are a variety of methods to treat acute pain, and it's usually effective if it is used properly, okay? Then, on the other hand, there's something called chronic pain. So chronic pain is pain that persists for more than 3 months. Why 3 months? 3 months is actually a ballpark figure because most tissues in the body will heal within 3 months.
Right, okay.
So if after the tissues have healed, the pain persists, then it changes a category. Then something has gone wrong with your pain signaling system, and your pain nerves are telling you there's pain even though there's no injury. So usually pain nerves only activate in response to tissue injury, right? But we know from research and we know from people's experience that there's such a thing as chronic pain where there's no tissue injury and yet you feel pain. So one of the big problems is that people think that I mean, when you have pain, you will go to look for the source, right? And if you can find the source, that's fine and well. So if you have pain in the tummy, you go and you have acute appendicitis, you go for surgery, you take out the appendix, throw it away, and then
the pain will
go away after
yeah,
the wound
because-
heals,
yes.
right? Because the inflamed appendix, the source of the pain, has been taken away.
Right.
Okay. But sometimes you may have abdominal pain and you don't have appendicitis, you don't have gastritis, you don't have, all the investigations are normal. Similar to back pain. Very often when people, back pain is the most common type of pain that people complain of
Yeah.
or people experience. I think most adults have experienced back pain sometime in their lives. And back pain could be due to an injury, could be due to something wrong, pathology,
Okay.
but it could also, all your investigations could be normal. And then people don't understand why you have pain,
Right.
you know, and people think that the patient, the person with pain, thinks that they haven't found it yet.
Okay.
They have to keep looking.
Okay.
So they keep doing more and
More
more
and more
scans,
tests,
more and more tests, you know. And they repeat the test, even though the first one was normal, because they hope that the second one will find something, you know. And the same thing with abdominal pain, with, you know, headaches and things like
Is
that.
that is not the? I mean, that's human behavior. Right? We want to find
but
the
that's
source.
the right thing to do.
Okay.
However, there has to be a point in time when you stop, because now we know that there is something, this chronic pain, we call it a disease of the pain signaling system, where there's something wrong, where you are getting pain signals without tissue injury.
Okay.
And the classical case that actually tells us that this happens is phantom limb pain. Have you heard of phantom limb pain?
Phantom
Limb
limb
pain,
Is
where
that
they
when
have an
somebody's-
amputation?
Oh, that's right. I have heard of that.
And yet they can still feel that the leg is there. Say the leg has been amputated, but they can still feel the leg and they can still feel pain from the leg. Now that's not possible, isn't it? Because the nerves, I mean the leg is not
No
there
longer
anymore,
there, yeah.
right? But the nerves that supplied the leg are still there in your body, in the spinal cord, and represented in the brain.
Wow.
So this whole system, something has gone wrong. It has a disconnect, a misconnect,
okay.
a misfiring, or whatever you want to call it.
So,
you know?
so has your career been essentially investigating this and implementing this into medical practice? I'm curious to know how you got into the pain field. Was this an area, particularly with chronic pain, was this an area that was considered a priority in mainstream medicine back when?
Not at all, not at all, you know. So how did I get into this is also a bit of a long story, but I'm an anesthetist. So I trained as an anesthetist, and in anesthesia, we look after patients during surgery so they don't have pain, right? We put them to sleep, we give them analgesics, strong painkillers during the surgery, and also we look after them after the surgery, because the wound is still there and they will still have pain from. So I initially started what we call an acute pain service, which is usually run by anesthetists, because you know we want to make sure that the patient recovers well after the surgery as well. So we treat the pain after surgery. But that's not enough, because you know some of these people there's something which we call chronic post-surgical pain. Sometimes in 10%, 20% of people after surgery, depending on the surgery, after surgery the pain persists after the wound has healed. Okay, so there's chronic pain. So what happened was that after I did acute pain, my boss, my anesthesia boss, asked me to go for more training in pain. And actually, anesthetists are people who don't talk to people, right? Because you are sleeping.
You don't have direct contact with the patient often,
So
right?
you talk to the patient beforehand,
Yes.
and then after that you put them to sleep, and then you don't have to talk to them anymore. So that was one of the things that attracted me to anesthesia. But if you do chronic pain, you have to run a clinic, which means you have to talk to people. So I was a bit hesitant, but I agreed. And the other push factor for me was cancer, patients with cancer and end of life, you know, and terminal illnesses, palliative care.
Okay.
Also, a big proportion of palliative care is pain management.
That's right.
And my father was a cancer survivor, and then he got involved with hospice, and you know, he was always asking me to do cancer pain management. I said, no, I don't want to get involved with all that, you know. A bit too touchy-feely for me, you know, that kind of thing. But then I said, okay, this is something that needs to be done because a lot of people suffer unnecessarily. Because it's treatable.
Right.
You know, this kind of pain we are able to relieve majority of pain from cancer, even from advanced cancer.
So you set up Malaysia's first acute pain service
in the Ministry of Health.
In the Ministry of Health.
The first one was set up in the University Hospital by Professor Ramani Vijayan, who is one of my colleagues and mentors, you know.
But you were very instrumental, if I understand correctly, in introducing pain as the fifth vital sign. Can you tell me a bit about that? I've heard of it before, but never... Lay people or people outside the medical fraternity may not understand. Tell us more.
So vital signs means is traditionally blood pressure, pulse, temperature and respiratory rate, and it basically tells you whether the person is alive or not, I suppose, because
basic
vital
signs.
And also, you know, it tells you whether you need to take some action or not. So if the blood pressure drops or the blood pressure is too high, you have to take some action. And similarly with the pulse and the, you know, the temperature, right? Those are actionable points. So there was a movement in the US in the early 2000s to make pain one of the vital signs, because just like blood pressure is invisible, temperature is invisible, you know, your heart rate is actually invisible. So you have to measure it in order to know whether you have to take action. So similarly, pain is invisible. You have to measure it in order to know whether to take action or not. So that was the philosophy behind making pain the fifth vital sign. Fifth because the others, there were four already.
Right. Can I ask you, because pain is self-reported, right? You said a scale of 1 to 10, and that's how it's essentially measured or determined. Can you talk to me a bit about how pain is understood by healthcare professionals, whether it's dismissed or undertreated? And I'm curious to know, because women's pain is often dismissed. Is there a gender dimension to this?
There is. So it's because of the disconnect, because it's self-report, because we don't have tools to measure it apart from the self-report. Our basic, in pain management, our basic principle is always believe the patient, okay? Because the patient is the one who feels the pain. The problem is, people take your body expression, your facial expression and your body language as also an indicator of whether you're in pain or not. And sometimes there's a disconnect. So you may report your pain score as 7 out of 10, but you may smile. So you say, how can you smile if your pain score is 7 out of 10? You know? So and this usually happens more with chronic pain than with acute pain.
Okay. Because you've learned to live with it.
Yeah,
right?
and also it's a matter, there's a cultural dimension to it, there's also a gender dimension to it. How do you react to pain? You know, men will not respond to pain because they're taught from young that they're not supposed to show it, right? But when they are in pain, somehow or other, sometimes they report it, right? But but people, well, I suppose I'm wrong, isn't it, when I talk about this? Because when men report pain, generally people will believe them because they don't have a lot of acting, they don't have a lot of expression, okay? Right. Whereas women, we are more expressive in terms of our emotional aspects, I think, to pain. So if you over-express, then people think that you are playing it up,
hysterical,
you know, so you have all those kind of biases that come in, you know, and often women with pain, especially with, and somehow the epidemiology studies show that chronic pain is more common in women than in men.
Really?
Okay, epidemiologically.
Chronic pain.
We don't know why exactly, but some people say it's due to there's some relationship with your hormones, you know, because of And but we don't know exactly why, but that's what the epidemiology shows, more common in women, you know. So women complain more about pain, and then they are not believed because, you know, when you do all the investigations, it comes back to chronic pain where you do investigations and it's normal. You can't find what's wrong with it because something has gone wrong with the pain signaling system, which is the way that pain signals get to the brain, which is not visible. Okay. Now we have something called fMRI, functional MRI, where you can image parts of the brain that are involved with the pain matrix. We call it the pain matrix. Okay, the parts of the brain that are activated when you have pain.
Okay, that's interesting.
So now with the fMRIs, we find that even without any peripheral pathology, there are people, when people report pain, their pain matrix actually lights up.
So you can kind of scan the brain to see how the body is reacting. Has the study of pain and pain management really evolved over the years? I'm curious to know, because I've also read interviews that you've done before or comments that you've made in the public sphere where you describe pain as multidisciplinary.
Right, right.
Can you explain what that means? Why is pain management needs to be looked at from all these different disciplines?
Yeah. So multidisciplinary approach to pain management, we call it, right? It's because pain affects your whole life. Pain doesn't just affect the arm or the leg or the back or the, you know, the part that is affected, right? It affects your activities, it affects your mood, it affects your relationships, and so many things. So it's all encompassing. So if you just look at it from a physical point of view, what we call a biomedical approach, and try to just target where do you think the pain is coming from and then get rid of that pain, you may succeed in an acute pain situation like acute appendicitis I described just now. But if it's a chronic pain situation and you cannot take away the source of the pain because it is in the whole system, then what do? You have to actually address it in the whole person.
Okay.
So when we assess people with pain, we actually have to assess not just the pain, the physical part of the pain and where the pain is and where we think it's coming from, but we also have to assess the impact of the pain on the person's life. So what are the activities that you have stopped doing because of pain? You know, and then when you stop doing activities, what happens to you generally? What happens to your fitness level will reduce. And you become more stiff, and then that sets up a bit of a vicious cycle. A lot of people with pain also go for many treatments and many investigations. And every time they go, they think they're going to be cured. And every time they go, and then the doctor says they can't find anything wrong and there's nothing I can do for you, what happens? You feel disappointed, you feel, you know, discouraged, and so that affects your mood. When you're not active and you are less fit, what happens to your mood? Your mood also will be affected, right? You don't feel like doing things, you feel lethargic, you know. Your sleep may be affected. Your relationships, because you isolate yourself, you don't want to, sometimes out of good intentions, you don't want to disturb other people.
You don't want to be a burden to them or
so
something.
you isolate yourself, and then people think, oh, you know, what's going on with you, you know, so you have problems with relationship. You may lose your job because you have to take a lot of sick days.
That's right.
You may lose your job because you can't perform. And, you know, so it manifests the effect on your mood, impact of pain on your mood can manifest in different ways. It can manifest in isolation, can manifest in anger. Okay,
it really does affect almost every aspect. If you are dealing with chronic pain, every part of your life is affected.
So if a doctor just looks at, you know, is the pain coming from your leg and I'll give you an injection or a pill for the pain, it's not going to just change everything else, isn't it? You know, so we have to, when we assess from usually three broad angles. One is the medical side. Is there any medical condition that is treatable, that has been missed, there any more tests that need to be done? This is from a pain clinic point of view when we have a multidisciplinary pain clinic. Then we have the physical assessment, which is usually done by a physiotherapist to look at physical and functional. What are the things you can do? What are the things you cannot do? Where you are weak, where you are stiff, you know, your range of movement, and so on and so forth. And funnily enough, a person may have, I had a patient with pain in the upper limb, in the arm, but he was limping.
Oh.
Why was he limping? Because in order to protect the arm that is painful, he changed his posture.
Compensate,
so when he,
the body compensates.
then when he changed his posture, he put different pressure on the limb, so he also limped.
Wow.
So it can affect other parts of your body that are not the painful part as well. So we have to do a physical examination. And then the third member of the third aspect that is assessed is the psychological aspect, the psychosocial aspect.
Okay.
So of course, doctors also have to look at psychosocial aspects, but then we use clinical psychologists who are more skilled in this kind of assessment. And then when you talk about management, then you have to talk about not just medicines or nerve blocks, but you also have to talk about what you have to do physically, how you have to start exercising again, and how you can start exercising with pain. You say, doctor, I can't do it. I tried, but I can't do it because it's too painful, right? So what do we do? So we have techniques. We measure what we call baselines. You start small, you do a little bit, and then you build up on that, and the physiotherapists in the pain team are very skilled at that. And then at the same time, we also use relaxation techniques which are taught by the psychologists. Of course, the doctors can all teach this, but doctors always have no time, right? So,
but it's great because it's all the different disciplines coming to address how pain affects your life, right?
Yeah. And in different people, the emphasis may be different.
Yes.
So somebody maybe say, I still go out, I still socialize, but I really can't do any exercise and I'm really putting on weight and this is really making me...
I really like that because I have to say before our conversation, I only viewed pain management through drugs, through pharmaceuticals, right?
And that's exactly what most people think, including, unfortunately, doctors and healthcare professionals.
So your work is really trying to change that. Now that you have been for many years involved with the International Association for the Study of Pain. When you look at how other countries manage pain, are we adopting similar best practices? Is there, do you see the differences in way countries approach pain, maybe even culturally or how they view it?
I would say that I was trained, my pain training was in Australia, and Australia is quite advanced in this whole multidisciplinary. Now we call it interdisciplinary approach because multi just means involvement of multiple specialties, but inter means involvement and collaboration.
Oh, that's great. Okay.
So but it's a terminology,
Semantics
but multi is really the word that has been used for many years. So I still use multidisciplinary. But anyway, so in Australia they have developed that very well. And in Malaysia we try to implement it, but it's difficult. It's difficult because we don't have enough people in the different fields who are trained in this aspect of pain. So doing a nerve block or giving a pill is easy, right? It's part of a doctor's basic training. So and people with pain go to many different doctors. They may go to a rheumatologist, they may go to an orthopedic surgeon, they may go to a neurologist, they may go to a neurosurgeon. So there are so many people who need to know this kind of approach, and most people, we just treat people according to what we know, what we have been trained in, right? So the orthopedic surgeon will either do surgery or do a block, or the neurologist will give a nerve medicine.
So the challenge is in trying to get people to think outside of their field of specialty.
Yes, and to think of the person as a person rather than as a pain,
Oh, yes.
So orthopedic surgeons just look at. I shouldn't talk.
No, we're not speaking. We're speaking general. Generally, yes.
But so usually you just focus on your area of expertise, and then you treat according to your area of expertise. So which is good, but in fact, that's why working in a team is much more powerful because you have not just the viewpoint but the expertise of other people as well. And very often in my experience when we have these team meetings, so we assess each of us will assess the patient, then we have a meeting to discuss what we have found. And when we assess, when we have our meetings, we discover that, oh, that's something that I didn't know, or I didn't find out, the patient didn't tell me, but he told the psychologist, for example, you know, that whatever other difficulties they're having, you know. So it really enriches the assessment, gives you a more complete picture, and also then I don't have to worry about, oh, how am I going to deal with all the emotional stuff, you know.
No, but this is wonderful, because I love that there are different perspectives of the patient, of understanding how pain affects the patient's life. In the minute or so that we have left, can I just ask you a message for our audience tonight? What would you like them to know about the work that you do in terms of pain management? I'm sure many people have chronic pain or know people with chronic pain in their lives. Is there something you'd like to express to them?
So I would like to say that first we must realize that acute pain and chronic pain are different. Acute pain can be relieved, and please, when you go for surgery and you have your whatever, if you have a fracture or whatever, ask for pain medicines, okay, or pain relief, because it's your right, and it helps you to heal better. But there's such a thing as chronic pain, where if you have done all the tests and there's nothing wrong, it doesn't mean that you're imagining the pain. Pain is still real. The pain is still real, and you have to learn how to manage it. So people with chronic pain actually have to go to a healthcare professional who takes a more holistic approach.
Right, wonderful. Advocate for yourself, right, when you are managing your own pain.
Yeah, and it's possible to manage pain, and it's possible to live a normal, productive life with pain. We have many patients who have done that, you know, and I wish you could interview the patients, because they are fantastic. They learn how to manage, and then even though the pain is still there, they can live a normal life.
Sometimes it is
Get
quite
back
discouraging.
to work with their families and so on and so forth.
I can imagine that somebody living with pain probably thinks, you know, my life has been
over.
so impacted, it's over. But there are ways to live with chronic pain. Thank you so much, Dr. Mary. I've so enjoyed learning more about pain management today. And thank you so much for sharing your work with us. I appreciate your time.
You're welcome.
That's all the time we have for you on this episode of The Future is Female. I'm Melisa Idris, signing off for the evening. Thank you so much for watching, and good night.